Today's lecture is on the hip and the pelvis. This slide shows you the three bones that make up the pelvis. You can also see the articulation of the pelvis with the sacrum and the pelvis with the femoral head. Take note that the acetabulum, where the femoral head articulates with the pelvis, is made up of each of those three bones: the ilium, the ischium, and the pubis. Review these bony landmarks of the pelvis, what muscles attach at each of these areas, and if you're able to palpate them. We will be doing palpation of some of these in lab to help us with our range of motion and manual muscle testing. Also, review the bony landmarks on the femur. The SI joint, or sacroiliac joint, is a joint between the sacrum and the ilium. You see that the joint surfaces are irregular in shape and with ridges. They also are covered in hyaline cartilage. There is minimal movement at this joint. Most of it is caused by movement at other joints. We will not measure any range of motion at the SI joint. You also see listed there a list of the ligaments that surround both anterior and posterior of the SI joint. When you look at this, check it out in your textbook or actually on the video that's at the bottom of the page, and you'll see that anteriorly there is less surface area covered with ligaments, whereas posteriorly it is quite thick. And why is that? Well, it helps to provide more stability. It also provides a lot more safety with the nerves that are exiting posteriorly to protect from impinging or causing injury to those nerves. You see that the SI joint is designed for stability, has minimal amount of motion. I do want you to watch the video. I have posted that under this module. Also, you can see that the sacrum moves in nutation and counter-nutation, which is a slight anterior and posterior movement of the sacrum, goes along with anterior and posterior tilting of the pelvis. The hip joint surface is a deeper surface with a labrum to deepen the joint surface and to provide for increased stability and decreased mobility, especially when compared to the shoulder joint, which is another ball and socket joint. There are three main ligaments of this joint: the iliofemoral, ischiofemoral, and pubofemoral. So going each from the bones of the pelvis onto the femur. Let's review the arthrokinematics of this joint. So if we have our femoral head moving on the acetabulum, so we have convex moving on concave. So the roll and the glide are going to be in opposite directions. So if we look first at, say, hip abduction, we are going to have the roll will be superiorly and the glide will be inferiorly. Please review these and ask any questions in class if you do not understand. This slide groups the hip muscles by way of action. In our manual muscle testing, we will often do groups of muscle tests, so looking at what are the hip flexors, and sometimes we will be able to dissociate between the two. Sometimes we'll be able to test for glute max, different than hamstrings. So this slide is just a review for you to look over the muscles. Now we will start to look at some common clinical conditions for the hip. A pelvic fracture usually occurs with trauma, whether it's due to a fall or a motor vehicle accident. And depending on where the fracture occurs and whether it's considered to be a stable fracture or unstable fracture will depend on how we progress in therapy. Common fractures that would be considered stable is if there's an avulsion fracture or part of the ilium, so where the muscle will cause part of the ilium to break free. Or other more stable fractures would be of the superior and inferior pubic rami and other parts of the ilium as well. If a fracture is considered to be stable, there will be some rest involved, as well as doing protected weight bearing, meaning they will probably be able to put some level of weight bearing through their limb, but using a walker or crutches in addition, so that they probably would not be full weight bearing. But we are going to get these patients up and moving, and a lot of times sooner than they think they should be. I've had patients where I've come into their hospital room and they're like, well, I broke my pelvis, or, I shouldn't be up and moving, and that is quite the contrary. Typically, if it is a stable fracture, they should be healed within 4 to 6 weeks and be fully weight bearing. Now, if the orthopedic surgeon determines that the fracture is not stable, the treatment can be an ORIF, an open reduction internal fixation, or maybe even using an external fixator, where you'll have the hardware on the outside of the body. These people are going to take a lot longer to rehab. It'll be longer till they're even able to be weight bearing, and probably be looking at a 4 to 6 month rehab. And again, the progression is you'll begin with some gentle strengthening isometric exercises, and then progress to active exercise and closed chain exercises.
Hip fracture is a very common orthopedic condition which occurs in the geriatric population from a result of a fall. Caucasian women have the highest incidence of hip fractures, partly because they also have the highest incidence of osteoporosis. And the older the patient, the greater risk of death from complications from a hip fracture. In fact, your textbook reveals the following statistics: that mortality rates are at 20% within the first year following a hip fracture, and that only 20 to 35% of patients regain their pre-injury level of independence. Most hip fractures are going to occur at the femoral neck or at the intertrochanteric line, because the bone is more callous at this portion of the femur, as well as a poor vascular supply to these areas. You can see both of those fractures in the right upper hand corner of this slide. These patients are going to undergo surgery and have an ORIF, an open reduction internal fixation, with screws or possibly a plate. We will see them in the hospital, the PT, on post-op day number 1 to do evaluation, as long as they are medically stable, looking at blood values, hemoglobin, because they may have lost some blood during surgery, and checking their vitals. You'll see that they will have sutures or staples and be covered with a dressing. You may even see a drain coming out of that area where it's collecting the fluid, or they could be even draining through their bandage. Also, this patient is going to have the compression pumps on their calves to try to prevent blood clots from forming, as well as they'll also have the compression stockings. So in physical therapy, we are going to try to get this patient up and mobile. With the plates and the screws, they are probably going to be touch-toe weight bearing. It will be according to the orthopedist and the surgeon who completed the surgery. This will be part of the order. So when the order is received for physical therapy, it'll state what the weight bearing status is, and if it doesn't, the PT will have already clarified that with the doctor or the surgeon. So we will focus on bed mobility, transfers, looking at some active range of motion exercises above and below the joint as well, isometric exercises, and trying to get them to a level of independence, or to a level where they can go to the next level of care, whether it is home independently, home with family, skilled nursing facility, rehab center. Typically, the length of the PT intervention from acute care to outpatient is going to be a total of 6 to 8 weeks. A total hip replacement or total hip arthroplasty is a surgical procedure where both the femoral head and neck and the acetabulum are replaced with a metal prosthesis. This is done for patients who have severe osteoarthritis, rheumatoid arthritis, or bone cancer. Also can be done when they have the severe fracture, hip fracture that we discussed in the prior slide, when it does not heal. It can also be done for pain, and sometimes needs to have a revision because they do wear out over the years. So signs and symptoms. These patients, we're going to get them up and moving early. We don't want them to develop complications for being immobile. So sometimes the physical therapist will even do an evaluation on the day of surgery, depending on how early the surgery was and how recovery of sensation. This patient will have staples and sutures, and usually will have a pretty thick bandage, at least to begin with, maybe day 1, day 2, with an incision. You'll often find them in their bed with an abductor wedge to help prevent dislocation. So if we talk about these precautions, it is dependent upon the approach that the surgeon takes. If the surgeon takes an anterior approach, so that they do the incision anteriorly, then the only precaution is combined extension and external rotation. If the surgeon takes a posterior approach, then our patient's limitations or precautions are hip flexion no greater than 90 degrees, no internal rotation, and no adduction. This one is pretty common, this approach. And we really have to do a lot of educations with our patients for them to understand what these motions are. For hip adduction, that is any time that we cross our legs. How many times have you had your legs crossed while you're watching this PowerPoint? Or hip flexion, they'll understand that in sitting or standing, but then you ask them to put their shoes on and they bend right down to their toes, breaking that precaution. So this requires a lot of education on the part of the PT or the PTA. And often these patients will have to maintain these precautions for up to 6 months, or maybe even for the lifetime of the prosthesis. Early on, we're going to be really focusing on transfers, bed mobility, gait, and then looking at muscle strengthening and range of motion. We may even need to do some soft tissue work to release some of the muscles if they've had some tightness develop over the lack of mobility that they've had, maybe even prior to surgery. We'll do isometric exercises, progressing to open chain, and then also closed chain as well. Now, as we're talking about mobility, it also, the weight-bearing status of the patient is also dependent upon the approach that the surgeon takes. If the surgeon cements the prosthesis, then the patient will probably be weight bearers tolerated and begin walking with a walker, immediately after surgery. Now, if they don't cement it and have a more porous prosthesis where they rely on the patient's bone growth to provide stability for the prosthesis, and this patient's going to remain touch-toe weight-bearing or even partial weight-bearing for up to 6 to 12 weeks. Typically, this patient who's had a hip replacement or total arthroplasty, we'll see them in acute care, but then they're going to continue to receive physical therapy, whether it's at a skilled nursing facility, inpatient rehab, home health, or outpatient. Typically, the total length of physical therapy intervention is 6 to 12 weeks. This slide shows the difference between a total hip replacement and a hemiarthroplasty or a hip resurfacing. You see on the left-hand side, there is a metal prosthesis that is for the femoral head and neck, as well as the acetabulum. On the right side of the slide, you see the hip resurfacing or hemiarthroplasty, where the femoral head is what is replaced by a metal prosthesis. The acetabulum remains as before. Often the hip resurfacing or hemiarthroplasty will be done with younger patients. These will not have precautions as with the total hip replacement. It is not usually done in people who have osteoarthritis, because if they do have osteoarthritis so severe, then they're going to need the prosthesis for both the acetabulum and for the femoral head. This slide shows the schematics done during surgery. So you see that both the femoral head and neck is removed, as well as the acetabulum, and a metal prosthesis is used. Here's another view of the prosthesis being inserted for a total hip replacement or total hip arthroplasty. You can also see how the acetabulum is secured into the pelvis with screws. Trochanteric hip bursitis is when the iliotibial band or the IT band rubs over the bursa lateral to the greater trochanter. This friction that causes an inflammatory process where the patient will have pain and be tender right over the greater trochanter where that bursa is located. They will probably have a tight or limited IT band, which is why they're having that increased stress on the bursa. They will have increased pain with weight bearing and feel better with rest. And when we do the special test of the Ober's test, they will be positive for a tight hip type IT band. So what are we going to do in therapy? We're going to start with modalities to try to decrease pain and inflammation to that area. We're going to incorporate a stretch of the IT band to try to take away the cause for this inflammation, and we'll work on some hip strengthening, and as well as we'll do some education to, while they're inflamed and painful, that to decrease or change their activity level. Typically, the length of PT intervention is 4 to 6 weeks. A slip capital femoris epiphysis occurs at the oblique angle of the femoral head in the acetabulum. The forces actually produce a shear force, which causes they occur and affect the growth plate, especially in our pediatric patients. So the femoral neck will slip up and anteriorly or cause the epiphyseal plate to slip down and posterior. Once the slippage has occurred and it's unstable, it can affect the vascular supply to the femoral head. And if the femoral head does not receive the blood supply that it needs, it will die and we will have avascular necrosis occur. This is a condition that usually affects adolescent males, often more those that are obese and have a valgus deformity of the hip. If you are unsure of a valgus deformity, please let's discuss this in class. They will have signs and symptoms of mild to moderate discomfort in their hip. You'll see a progressive, so a worsening Trendelenburg gait, and also their hip will be more in an externally rotated position. So after they have surgery, because they will need to have an open reduction internal fixation to stabilize the joint, they're going to be non-weight bearing, partly because of this vascular supply as well as it being near the growth plate. Then we will progress as instructed by physician for range of motion exercises, gait training, and the length of this really can be variable depending on the severity, from 1 month to 1 year recovery. So these will all be our patients. And so we must know how to accurately measure goniometry as well as manual muscle test, and then be able to decide which exercises are going to be best to try to strengthen this patient and get them back to their prior level of function. In addition to goniometry, manual muscle test, and special test, I also want you to review your myotomes and dermatomes of the lower extremity. We can do deep tendon reflexes, look at proprioception of the lower extremity, as well as girth measurements to look for either muscle atrophy or edema.